I just pasted that one in there. And then there's another link that will be for anybody else who wants to watch the afternoon session but not participate, and that should be on YouTube. So that will be at 2 o'clock. We ask that all the scholars join the afternoon session after this morning session. So let me introduce myself. As my name states, I'm Tim Lazan. I am a co-director of the CompBio Academy, but this year, for the last couple of years, things have been changed. This is really an academy that has been, or a site that has been led by Joe Ayub, who is also here. You can see his smiling face on the camera on your screen. We're happy to say that this was another successful year. I do want to go over just a few kind of nuts and bolts details with this this particular session in the morning. I gave myself 10 minutes to talk, so I'll just keep going for another 6 minutes. There's no problem with that. No, I don't want to show that. Here we go. Right, so just some basic rules. First of all, these sessions are being recorded. You're being recorded right now. That's just so that everybody has some record of what has happened. You can go back and watch that. If you're not comfortable being recorded, then please, you can use the chat if you have questions and you don't want your voice to be recorded. If you don't want your face to be recorded, you can keep your cameras off. We ask in general, just as a common Zoom etiquette, just please mute your microphones unless you have the floor, which means if you're currently presenting or if you're introducing one of our scholars or if you're asking a question. People tend to get a lot of background noises from Zoom. So for our speakers, please turn your cameras on during the presentation. It's nice to see who's presenting. But again, really, we're not going to force you. But it's always nice to see who's doing the talking rather than just seeing slides and hearing somebody's voice. The format of the talks are going to be that each speaker is given 10 minutes, and I will notify you when 1 minute remains. And I'll just do that by interrupting you and saying, hey, 1 minute remains. And then you should wrap it up at that point. We just ask you to, be aware of what the time is. We're going to be a little bit relaxed. We've allowed some extra time, but we do want to stick to our schedule. And we've given some time for questions. And questions can come from anybody. They can come from the other scholars. They can come from members of the audience, from the other mentors. So please feel free to ask questions. Pay attention and ask questions, because a lot of hard work has gone into this, and I'm sure that these scholars are expert in their respective fields and in their projects, right? These are projects that they have been working on, so they know them better than anybody else. And you can feel free, please, to ask your questions just aloud or to post them in the chat, and then I can ask on behalf of audience members. And then once again, I want to remind our scholars to attend the closing ceremony at 2 p.m. And then anybody else who wants to watch the closing ceremony, that will be available on YouTube, and I've already put the links in the chat. So we have 2 sessions today. The first session is going to be starting shortly. We might even start a couple of minutes early, depending on how much I talk on. And we have 6 speakers in our first session. And then we have a short break starting at the end of this talk. I think that would be probably around 10:40. So just a simple break so everybody can check their emails or Twitter feeds. And then at 10:45 we'll come back and we'll have our second session. So are there any questions on this, on the format? And am I missing anything? Oh, the final thing is I do want to ask that the mentors should introduce their scholars, right? Because the mentors know the projects, they know the strengths and weaknesses of the scholars. So please, what I'm going to do before each talk is just mention who the next speaker is and who the mentor is, and then please, mentors, take a few minutes to talk about your scholar, tell us what they did, a little bit who they are, and that's it. So we're about 2 minutes early. but that's all right. So then I think that we can start if there aren't any objections to that. So our first speaker is Helen Zhang, who will be introduced by Catherine Bender.
Good morning. It is my pleasure to introduce Helen Zhang, who is a junior at Winchester Thurston Academy. And we have had the pleasure of working with Helen this summer. Our research focuses on neurocognitive function and brain health in women with breast cancer. And we have a particular interest in accelerated aging and factors that influence aging in people with cancer. And one of those is a concept called neighborhood deprivation that I'm going to let Helen introduce to you. But in short, it speaks to the exposure a person has where they reside. It has to do with their socioeconomic status, the crime in their area, and essentially the amount of stress that they experience associated with where they reside. And so Helen was quite interested in this concept, and we're in the midst of conducting an analysis of some of these data, and so she was quite helpful to us in exploring this concept in more depth and doing some descriptive analysis of our data. So on behalf of my team, we want to thank Helen for the work she's done this summer and for the pleasure of having her on board this summer. And we look forward to hearing more from her and all the exciting things she's going to be doing going forward. So with that, I'll turn it over to Helen.
All right, thank you, Dr. Bender. Can everyone hear me fine? Just making sure.
Yes.
All right, so then I'm going to share my screen. So like Dr. Bender said, I'm Helen Zhang. I am a rising junior at Winchester Thurston, and she is my mentor. And my presentation is called The Utilization of Neighborhood Deprivation and Statistical Analysis to Improve Outcomes in Breast Cancer Survivors. So what is neighborhood deprivation? Neighborhood deprivation is defined as a geographic area based estimate of the level of quote unquote deprivation of a neighborhood based upon income, employment, education, health, crime, housing, and just generally the living environment. So how is neighborhood deprivation measured / determined? Well, basically it takes into account several aspects of the neighborhood someone would live in. Like it would take into account the obvious factors like socioeconomic, like the socioeconomic atmosphere in there, the safety, as well as access to like beneficial resources, which can include school.
Can you please all mute your microphones if you're not speaking?
Which includes, like I said, socioeconomic atmosphere, safety, access to beneficial resources, which can be like school, healthcare, but it can also include like a variety of things. Like for example, access to supermarkets, so like you can walk to it or drive to it in an easy distance where you can have access to healthy food, or just even like a playground. So you can so if you have children, they can get your energy out, or like parks or something. So you just have an outlet to like relieve stress. And neighborhood deprivation is important because it's often associated with poor health and just health behaviors in general. So things like obesity, which is connected to like having access to healthy and nutritious food, reduced physical activity. Maybe you live in like a area where there's high crime and it's not safe to go outside, poor neurocognitive function, as well as poor cancer survival outcomes, which is one of the main emphasis of this basically this slideshow. So introduction to the neighborhood atlas. So during this project, basically the statistics I was given to by Dr. Bender and Amanda Gentry were basically from the Neighborhood Atlas, which is a neighborhood slash area deprivation index, and there's the abbreviation there. And it was developed by the University of Wisconsin-Madison. And basically what it is, it's a collection of data from, which is a 5-year average from the American Community Study, which is a survey by the US Census. And basically it's adjusted for every year that we're on. So if like we're on 2021, it would be an average of the data from 2016, 2017 to 2021. So I'm just gonna go over a little bit of how to use it. So basically, once you select a state, it's only in the United States. There are 2 options, which is the state-only deciles, which is just the neighborhood state rankings. And then there are the national percentiles, which is how like neighborhoods rank nationally. So I have 2 examples here just to show the possible difference it can really make when you look at the 2 sets. So as you can see, Alabama and California, they're kind of on like the opposite like spectrum of wealth, which is why I chose them. So as you can see with Alabama here in its state decile rankings, Alabama has like pockets of blue and pockets of red. So that would mean like, it seems like, yeah, there's like just as many disadvantaged neighborhoods as there are advantaged. And if we take a look at California's state decile rankings, we can see that there seems to be a lot more red here, which indicates that California seems to be very deprived in most areas. But if we look at the national percentiles, we can see the opposite is true in that Alabama seems to be more disadvantaged, while California seems to be less. And this is just because California is just in general a wealthier state. So it's going to rank better nationally than Alabama would, which is not necessarily the exact opposite, but they're on 2 different spectrums. So that's where the difference comes from. And as you can see, the state decile rankings don't always correlate nationally. So before I get to my data, I just want to give you a project overview, which is I started off by reading literature, just reading on the topic since I didn't know much about it. And where I got this literature from, which is PubMed, which is like a search engine where you can find a bunch of just like medical papers just all there. And also I had readings provided by my mentor, which was really helpful. And as she said, that's where my interests came from. So after that, and after learning about the topic, I started calculating. I was given statistics by my mentor. So basically a statistical set, which had both the state and national rankings from when we mentioned previously on the area deprivation index. And what I did for this set was calculate the mean, median, and standard deviation. And after that was done, I graphed the data so we could better visualize it, like just better visualize it. And then after that, we did an analysis, like we basically did an analysis, like what does this mean? We compared the 2 to find trends and whether they differed from each other or not. So now onto the sample details. So my mentor gave the aforementioned samples that my mentor gave. So basically, it was a sample of 148 participants who were all breast cancer survivors and who all resided in Pennsylvania. And for each, like I said before, there were 2 neighborhood deprivation rankings for each person, which was the state decile and the national percentile decile. So the patients had no identifying factors. They only had their patient IDs. We weren't told which neighborhoods they live in. We weren't told their age or their race. So it was just a blind study where it's just like participants and we only knew their neighborhood information. So with the sample, I decided to look at the the area deprivation map for Pennsylvania to see what I could derive from that. So from what I looked at it and what I gathered, Pennsylvania neighborhoods rank lower nationally, but there's little difference overall between the state and national data. So as you can see, there's the state deciles, and then there's the national percentiles. So basically, as you can see, when we transition over, there's a little bit more red, but it's not, but like the comparisons before, it's not as drastic like Alabama, where it's went very red, or California when it went very blue. There's like a little bit of fluctuation, like the lighter blues turn into the bit lighter reds. But in general, there wasn't any extreme difference. There's not any real extreme difference between the two. So with that in mind, I crafted a hypothesis for the statistics as well as the general trends of the data. So next, I'll read it. Because Pennsylvania ranks just below the middle of the states with respect to neighborhood deprivation, we hypothesized that there would be little difference between the state and national deprivation data for the state. As for the raw numbers, we expected that the data would remain similar, with the exception of being scaled up by a factor of 10 to be adjusted for the neighborhood national decile ranking system. So basically, we just expected Pennsylvania, the state data, to be similar to the national data. And for like the raw statistics, like the mean, median, standard deviation, we expected it to be scaled up by a factor of 10, but still remain with similar trends, because the national ranking system has like a more comprehensive rating system of 1 to 100, but the state data only has a ranking from 1 to 10. So after calculating the mean, median, mode, and standard deviation, and after graphing all of that, this is what we ended up with.
1 minute, Helen.
All right, so some areas of the graph didn't differ much, but others, particularly the middle, as you can see with the state and national rankings, they really did. So there's little difference in the most extreme areas, but in the middle, and also these are just like how many times this occurred within the data set. But basically, as you can see, there's a lot more So basically, so first I have to say that the range, so instead to account for like minor fluctuations for the national deciles, I basically put them in a range, and then that's how many times a number within this range occurs. So these are the numbers of times it occurred. So as we can see, the mean, the median, they both remain the same, exception of this factor being scaled up, and the standard deviation too, but with the mode, that wasn't the case. So basically, the most common occurring was the least deprived neighborhoods, like in state. But when we look at the national level, we can see that there was a lot more fluctuation. And basically, the one basically transformed into like the mode was now basically a 3 or a 5 if we were to translate it back. So there was actually a lot of difference that wasn't expected. So here's my conclusion. My hypothesis only proved correct for certain areas of the graph, but there was actually a lot more variability throughout than we hypothesized. So how can this data be used? So it can be used to address public health on a case-to-case basis. As we've learned, like healthcare is becoming very more individualized, like more catered towards the individual, and this can really help with like addressing certain cases. This can also guide the development of health interventions. So maybe with this information, we can intervene quicker, or like we can consider, or we can basically like cater towards certain areas. And also the main thing about this presentation is the quality of life for certain patients can be improved. So which connects to the two. So if we're able to do these two better, we're able to do the last one better. But further research still needs to be done on this topic. So it's great that we've already been doing research, but we need more diverse representation. And this is partially due to distrust of research. Like some groups don't trust like medical institutions as much as others. And also the location of the study, like you might not have access to the most diverse populations. And also a larger sample size is needed. We would probably need like 148 is a good start, but we need to like scale it up. We probably need to include like a wider range of people, and also connecting with that, we need more factors to be researched. And this can include things other than neighborhood, like age, like how many addresses people have lived in, just a variety of other factors. There are so many factors that can play into this. So that's what needs to be done in the future. But with that being said, that's the end of my presentation. So here are my papers and my references. And a big thank you to Dr. Bender, Amanda Gentry for providing me the statistics, Bergen, who was our basically my like editor. It's like he's like the Dr. David Boone, Solomon Lifshitz, and the Hillman Cancer Center.
Okay, thank you.
Thank you. How do I stop sharing my screen?
Stop sharing at the bottom.
All right.
Okay. We have time for one quick question.
Hi, Helen, great job, thanks. Maybe I'll ask a quick question here. So you're talking about what you would do next and maybe some of the other factors you could bring in. What would you like to bring into the study, or what would you like to do next for this project?
So basically there's a big connection between age. So I would like to consider that like what life experiences people have gone through, definitely. But also since like there are so many, like I said, these studies were blind, so we didn't know much identifying factors. Maybe we could do more. Maybe the patients could give like more we could get more information from patients, because definitely like some more individual factors play into that. So
how many more patients would you like to include in this study? What scale should this be at?
So yeah, 148 I think is a good start, but it's like very specific. So I would definitely want to have a wider range. So like I said, more diverse, but I think it would be nice to be like in the thousands, like something like a clinical trial would be nice, but that's just such a big scale. So we'd have to just work our way up first, say.
Okay.
Okay, thank you. Thank you very much.
Nice work, Helen.
Thank you.
Yes, okay, so our next speaker is Samaree Perkins, who will be introduced by Nathan Liang.
Great. Hi, everybody. My name is Nathan Liang. I'm one of the vascular surgeons here and faculty in the Department of Surgery here at the University of Pittsburgh. The focus of our research group is primarily in abdominal aortic aneurysms, both discovering why they exist, how we can predict them, how we can fix them, and how we can improve the outcomes of people who undergo these types of operations with this condition. I would love to introduce Samaree Perkins. She's a rising senior at the Barack Obama Academy of International Studies. She's been working with us over the last 2 months. She is, in addition to being part of the program, she's a stellar basketball player and impressively has been juggling some things like Basketball Travel League and trying to get scouted for colleges. But has been making an incredible effort to learn all about research, what we do and why we do what we do. She's been working with us in our research group on studying how to improve care for patients with abdominal aortic aneurysms. I, for one, am very impressed by how quickly she has picked up and understood some of the nuances of this topic. We've had some conversations about the finer points of aneurysm growth and what's next in the field, despite having a limited background in medicine and anatomy. So that's impressive. We're very happy to have had her with us, and hopefully we gave her a good introduction to clinical research. And if she ever wants to become a vascular surgeon in the future, we'll be here for her. Samaree, take it away.
Thank you, Dr. Liang. So I'm going to start sharing my screen. And Can everyone see?
No, not yet.
Is it still not working? Oh, never mind. I'm sorry. That's me. Now can you see?
Looks like it is coming.
It's just showing a blank screen. There it is.
There we go.
Okay, sorry about that. All right, so good morning, everyone. Again, my name is Samaree Perkins, and I'm a rising senior at Obama, and my project was called Code Rupture, and like Dr. Liang said, it was about ruptured abdominal aortic aneurysms. So what is your abdominal aorta? First, your aorta is the largest artery in your body, and it starts in the top left ventricle of your heart and travels primarily through your whole entire body almost. And it provides oxygenated blood to your major organs and lower extremities. So we'll mostly be talking about, as you can see on the chart, the part of the aorta that is in your abdominal cavity. So what causes a ruptured abdominal aortic aneurysm? So right now, medically and scientifically, we don't know why people have aneurysms, but we do know that when they do have them, they are very fatal. So these are things that we want to handle urgently. So they're usually found during routine examinations, but once you go to a specialist, they can be found on ultrasound, CT scans, and MRIs. We also do know that age, being older, gender, being a white male, smoking, and family history are significant factors for having or being more susceptible to a ruptured abdominal aortic aneurysm. And the rupture basically creates a bulge on the aorta, and I'll talk about that a little bit later. And once it gets to 1.9 to 2.2 inches, that's when surgery is considered by your doctor/surgeon. So your treatments, the more standard practice is called open repair, and an incision is made on the abdomen right above the rupture, and the rupture is exposed to the surgical field. And then this gray thing that you see on the right side of your screen right here is what is called a stent, and it is sewn into place, and it basically becomes your new aorta because those walls have burst. So, and then you're sewn up. It's sewn and it's stitched together. Stitched together and sewn into place. And yeah, and then you go to the ICU or care treatment facility. Well, and then the new aged or more modern surgery is called endovascular aneurysm repair, or Evar. And it is minimally invasive, which means it leaves a smaller wound, or like a smaller cut is used, so there's less damage to the skin. So it starts with a small incision that's made above the groin, and using a catheter and this guide wire, this is the little green thing that you see, it is inserted through a branch of the aorta. And then once it reaches the rupture site, it is placed a little bit above these two branches right here, so that the prongs can be attached to the two branches of the aorta. And then one is when the surgeon believes that it has been correctly moved into place and fits where it should, it is exited out the opposite side of where it came from. So that was just a little bit of background on what a ruptured abdominal aortic aneurysm is. So now I'll talk about what I actually did this time. So Code Rupture is a system of procedures implemented by Dr. Liang for UPMC Presby, and it follows that staff followed when patients presented with ruptured abdominal aortic aneurysms. So these situations were always emergent, and patients were either brought into the ER or they were brought from another hospital. So the way you activated Code Rupture was, so say someone was at a different hospital, and then they would call and UPMC Presby and be like, hey, we have someone who has a ruptured abdominal aortic aneurysm, and that would activate the code. So a helicopter would transport the patient to Presby, and then a communication system was set out to any medical staff that were going to be involved with the surgery, any nurses who were in the ER staff, and then surgeons, like, what are they? Yeah, so any other medical staff, anesthesiologists, sorry, I couldn't find the word. And then in comparison to before code rupture was implemented, there used to be some confusion about what operating room people were going to, what tools needed to be set up, and even small things like who was going to be performing the surgery. So that code rupture definitely helped make the system more organized. And then another important thing was the CT scan was always on file, so that, because that's very important, so that when the surgeon is actually performing the surgery, they know where the stent is being placed and it's know that it's being placed in the right area. So what more tangible work from code rupture was, I had to do a lot of reading from medical journals because I was coming into the study late. I also reviewed the data. So a year into code rupture, a survey was sent out to anyone who had ever participated in a code rupture, and I had to review that survey data and construct charts. And then I worked with Paige Phillips, who is a data analysis for UPMC, on learning the basics of RScript, which actually was very helpful because it changed my mind on programming. And so this first chart were just like the survey questions people were asked, like, what was your role in the team, or in what ways has code rupture improved patient safety? And then the second chart I created was the actual data that corresponded with the questions. This chart was a chart that was made on RScript. So the few main features are the pre-protocol group, which are the people who received a repair or operation for ruptured abdominal aortic aneurysms before code rupture. And the protocol group are the people who underwent code rupture or had a code rupture activated. And this information is really important for any type of, so Dr. Liang, after this, is writing a big paper to summarize his work and how code rupture has helped UPMC Presby. And for a clinical study like this, it is important to demonstrate that the patients haven't changed, but the procedure and standard practices that he implemented is what helped the outcome for the patients. And then the notable conditions from this study were prior health conditions, so CAD, COPD, HTN, smoker, cancer, different things like that. All coupled together with already, well, not already ruptured, but having an aneurysm, that just couples for more stress on the body, which makes you more likely to rupture. So those are very important. So how do we know that code rupture was a success? So the data on this chart right here, or this graph, is indicative that the arrival time from getting to the hospital to getting to the OR was lowered by 48 minutes, which is very critical for a patient who is internally bleeding, because again, this is very fatal. Like, all your blood is supposed to be going to different organs is now being rushed into your body cavity, which means your body's not working right and it's not getting the blood that it should. So that was definitely a goal of code rupture. So to lower that time, and they did indeed, because again, more organized. And like a lot of people on the survey said, that it helped organization and it really benefited the hospital overall. So as the mortality is the next thing that you see on the chart, and it doesn't really show much difference between mortality rates, but we're anticipating as code rupture goes on and we get more data that mortality will go down. But again, this study wasn't really to affect what goes on in the ER, but affect what happens before the patient gets there, so that their outcomes are better once they're in surgery. And code rupture has become more prominent. So like, change is different for everybody. Some people might like it, some people might not. But when people began to see how effective code rupture was, they began to like it more, use it more. Because as you can see, the protocol group here is 46, but the protocol group here is not 46. I'm sorry, I can't see it. But it's just different because people might have underwent treatment for ruptured abdominal aortic aneurysm, but just not under code rupture. Either way, though, it still shows that people are being more open to the idea of code rupture because it overall does better things for the patient and for the medical staff. So I just want to thank Dr. Liang and his team and all the people who were in the different Zoom meetings, different Zoom calls, Dr. Boone, Solomon, the UPMC Heart and Vascular Institute, UPMC Presby, and anyone who just contributed to this great summer. I really did have fun. It was really engaging. And if I had to do it all over again, I would. So thank you for listening. And does anyone have any questions?
Thank you very much, Samari. I do have a question. I want to start off and use my position to ask the first question. So it's really impressive that this protocol reduces the time that it takes to get the patient into the hospital, but then what else can be done to reduce mortality?
So I think one of the things that can be done to reduce mortality, so in the medical journals that I read, it did favor Evar over open repair. But again, a surgeon is in control of their OR, and it's up to them to do what they want with their patient, what they think is best fit. But just in terms of like everyone, even once they get into an OR, a standard practice, like, but every patient is different. So you have to take that into consideration as well. But I think just knowing more about ruptured abdominal aortic aneurysms, because we don't know exactly why they form. We think that it's because of family history, like that's the most significant factor. But if we can really get down to why do they form in the first place, then that can help translate to what surgery should use, open or Evar. And then from then on, we can continue to refine the system and the different tools that we use, the different people that we have in place once we're in the OR to change mortality rates.
Great, thank you. So I used up the question time. We can thank our speaker again. Thank you very much. And we can move on to the next speaker, who is Donovan Ellen, who will be introduced by Robin Lee.
I'll actually be.
Thanks again, Donovan. Okay, so now we can move on to Naya Tyler, who will be introducing that.
Hi, it's me. Can you hear me? Sorry, Dr. Zureikat is scrubbed in a case, so he will not be here, unfortunately. But my name is Caroline Reiser. I'm one of the general surgery residents that's been had the privilege of working with Naya this summer. And a little bit of background. So Dr. Zureikat's group and our pancreas research group is really focused on trying to improve the clinical care of patients with pancreatic cancer. And our specific arm is focused on addressing issues in access to care and particularly for complex cancer care, looking at roots, causes of disparities in treatment and survival, and trying to design clinical algorithms or clinical treatment pathways to help address some of these and ensure more equitable care. And Naya has really jumped in this summer. She has taken on a project that's pretty challenging with some really rare tumors, but we've been really impressed by her enthusiasm and her ability to, really leave a mark. She's brought a lot of her passion for social advocacy and community engagement into this work. And she's really made this project her own and helped shape it. And so we've been really impressed and grateful to have her on our team this month. So excited to hear the final work.
Thank you very much, Caroline. I will now share my screen. Okay, so can you hear me okay?
Yes.
Okay. Yeah. My project is on pancreatic neuroendocrine tumors. Just as Caroline said, I go to Pittsburgh Obama, and I'm a rising senior, and this is my project. So just for a little bit of background on PNETs, they are a very diverse group of endocrine tumors that form in the pancreas. They behave very aggressive and or it could be very slow growing. So that's why it's very important that each patient has personalized care by a team of doctors to make sure, you know, that if this person has, you know, very aggressive tumors, that they go with a team of doctors who are able to take care of those people who have aggressive tumors, and those who don't, they have a team of doctors, because with everyone, it's very different, it's diverse. And that's why it's very hard and rare, because everyone has to need specialized care and outcomes. And then you can see in this picture right here, we have a localized one right here. And then on the other side, you see we have a very aggressive growing one on the to the right. So our main focus is going to be socioeconomic and status in cancer care. Socioeconomic is defined as a social standing or class or individualized groups that is often measured by, like, it could be a combination of education, income, occupation. It is often revealed through the inequalities like someone may have between privilege, power, and control. So ours is going to mainly focus on like the measure and how those go. So like delays in diagnosis and decreased treatment and your overall survival rate, and does SES affect those things? So here we have an area deprivation index. You can see this is the area deprivation index of Pennsylvania, and you could just see like the red, that is very areas that are very vulnerable, and then you have the blue that shows areas that are very not vulnerable and who have made that increased care. So our aim is to examine the impact of social determinants on health, diagnosis, and patterns, management, and overall survival with patients with PNETs. So where our focus was race, the mental health history, marital status, and SES. The hypothesis that we came up with was non-white race and lower SES would be associated with a decreased rate of surgery and worse overall survival with PNETs. So it was important to look at all of these different things, because someone who was, you know, married may have the support that they need to help them get up and go to surgery and get to their places in their hospitals that they need to attend, and all make sure that they get everything that they need from, you know, that the care that they need. So it's all about support system, and, you know, with race, where area they come from, like those could all be factors of why, you know, their overall survival rate with PNETs was not the way that it could have been. So the methods and the way we actually studied and got all this information was the UPMC Network Cancer Registry. We used patients that were diagnosed with PNETs through 2018 to 2018 across all 16 UPMC hospitals. Factors that we looked in when we looked at these charts were age, race, marital status, SES, and mental health history. And the primary outcome that we also looked at was surgery, and secondary outcome, which is also survival after diagnosis. So over a time of years, a span of years, how did they do after diagnosis and their overall life expectancy. To look and analyze all of those things for the primary outcome, we did the logistic regression analysis. And for the secondary outcome, we did the Kaplan-Meier and Cox analysis. So this chart right here just breaks down how the percentage and how we basically, you know, looked at certain things. So overall, we looked at 365 patients with PNETs, and they 127 of them had metastatic disease, so very aggressive pancreatic cancer, and 30 of them had surgery and 97 did not have surgery. You can see the greater deal of those who had surgery had an overall survival rate of, you know, 5 years. 80% of them had an overall survival rate of 5 years, 80%. And it was that's just very good and very important to see that that surgery was able to save, you know, someone's life and add more years, whereas to some 97 of them who didn't have surgery, only had 23% of them had a 5-year overall survival rate. When we look at those who didn't have metastatic disease, 138 of them had surgery, 92% of them had a 5-year overall survival rate, whereas the 55 that didn't have surgery only had 69%. So that's still high, it's higher than those who had metastatic disease, those who didn't have surgery, but it's not as high as if you would have had the surgery, a full complete 5 years of overall survival when it comes to life. As a whole cohort for our results, looking at the whole cohort, only the major difference between low SES and high SES patients were that low SES had a higher rate of presentation with metastatic disease, 40% versus 30%. And when we looked at the analysis and controlling for other factors, low SES was independently associated with metastatic and a presentation with the odds ratio of 1.56. So that's just really important that we know all of this information. And additionally, when we looked at the survival for low SES, the patients had the worst overall survival compared to the high SES patients. So it's just, you know, when you look at the low SES, you see a 0.04. That's not really good when you compare it to the non-married 0.09, and then the Black who had the 0.75. Over on this graph here, you can see that the low SES had 75 months. Unfortunately, the high SES wasn't reached yet, and through the data that we had gathered. For the non-metastatic results with peanuts treatment and survival, the median survival did not get reached yet. But when you're looking at, we looked at it by survival stage. So looking at the non-metastatic patients, we looked into risk factors undergoing surgery. So controlling for tumor factors, and age was a very big one. Because you know, essentially if you're 70 or you're like 80 or in the high risk, you're considered high risk surgery, you know, you don't want to put a body under that certain decade under the stress of a surgery. So you can see where the 0.01 value of that just shows that it was, their odds were very low. The later in the decade you got compared to when you compare it to the undergoing surgery analysis with the other ones. So metastatic peanuts treatment and survival, there was no difference by SES. And you just look at non-metastatic patients, there was no differences in treatment. 20% of the low SES patients received surgery compared to the 25% of the high SES patients. And the majority of the patients got systematic therapy, 50% of the low SES and 58% of the high SES. And similarly, when we looked at the survival, there was no difference between the SES. You know, the only difference that there really was that when we look back at the other slide was the age, which really, you know, affected if you were able to receive that surgery or not.
1 minute, Maya.
So my conclusion was that low SES, you know, how we went over, low SES have higher rates of presentation with metastatic disease. They also had the worst overall survival. When you're looking by stage, metastatic or not, there was no difference in treatment and survival based upon social determinants of health. Again, the primary difference based upon was the age for non-metastatic patients. You know, it suggests that inequalities are primarily, you know, differences in stage of presentation. You know, if you were presented with, you know, pancreatic cancer farther on in life, you know, it's going to be harder for you to, you know, get that overall survival rate that you may want. And, you know, that's just things, you have to address interventions to focus on the increasing access to care and to reach out into those different lower SES areas and things like that. I would like to give a special thank you to, Dr. Boone, Dr. Evans, Solomon, my mentor Caroline, and my mentor Mr. Zurtek, Dr. Zurtek. I just also want to give a special thank you to the entire pancreatic research team, staff in the Department of Surgery and the Division of Surgical Oncology.
Thank you very much. That was a wonderful presentation. So are there any questions from the audience? We have some time for questions. I will start actually, if I may. So you mentioned that this study was done looking at UPMC hospitals. And if you're looking at socioeconomic status, were these patients going to the same hospital, or is it just that maybe one hospital which serves patients with, or differences among hospitals might account for these differences? That if you have a hospital in an area where there's a high density of people with low SES versus another hospital where there's a high density of people with high SES, then you might see these differences. Is that possible?
Yes, most definitely. It all depends on like the area and where you are and where you come from. So if if a hospital is in a high SES, they're obviously going to get better, maybe possibly better results. It also depends on, you're just going to get better results if you went to the high, or, if you, depends on, your access to care, like if you're able to go under surgery and, things in that nature can affect, even if you were a part of the high SES.
Okay, thank you. And Samari has a question. Is this a field that you can see yourself practicing?
I did really enjoy, working with everyone. So I can say I can see myself, practicing in this field in my, future. It could, I can definitely see myself doing it.
That's great. It's good to know that this is having a positive impression on you. So, are there any other questions? No. So thank you again, Naya, and we can move on to our next speaker, who is Sofia White, who will be introduced, I think, by Dr. Stephanie Outterson.
Hi everyone, I'm Stephanie Frisch. Sorry, it's Outterson Frisch, but it's fine. No worries. So good morning, everybody. We are, so Sofia joined us this summer from Walter Payton College Prep in Chicago, Illinois. She's been a tremendous help, kind of just making her own project of what we had of data. So my group looks at, so I'm an emergency nurse by training. A lot of my research just focuses on when a patient first arrives to the emergency department. And specifically, we're looking at right now acute coronary syndrome, or people that have had a heart attack, are going to have a heart attack. And this symptomatology, when people first come in, is like the driving force for how the patient is treated in the emergency department. So we're looking at using technology, specifically either machine learning or natural language processing, to see if we can come up with potentially new algorithms and standardizing the actual assessment that emergency nurses do when they first arrive to the emergency department. So Sofia has taken on a lot this summer. She's made her own project up and looked at cancer versus non-cancer patients. And we've kind of looked at symptomatology potentially between those two groups. So she's been a tremendous help, and we are excited to hear her results. Thank you. One second.
Okay, can you guys see that?
Yes.
So, hello, my name is Sofia White. I'm a rising senior at Walter Payton College Prep. This summer I was working with my mentor, Dr. Stephanie Frisch, and today I will be presenting on our research on extracting symptoms via natural language processing for acute coronary syndrome patients with cancer. So due to shared risk factors, the effects of cancer therapies, inflammation, and hypercoagulability in those affected by cancer, acute coronary syndrome is actually a common comorbidity of cancer patients. Acute coronary syndrome, or ACS, defines patients with acute symptoms of myocardial ischemia, meaning that they experience reduced blood flow to the heart. And the most common form is a heart attack. So cancer patients are almost 2 times more likely to experience ACS than the general population. And as survival for cancers improve, their intersection is actually expected to be more frequent because of the aging population and long-term effects of cancer control. However, diagnosis in this population might actually be more difficult because cancer patients may have a different symptom presentation of ACS than the general population. So minimal studies have actually documented symptom frequency for ACS patients with cancer, but researchers have previously found lower rates of chest pain, shortness of breath, and other common ACS symptoms on initial presentation. So ACS patients with a history of cancer are less likely to receive guideline recommended treatment and have worse in-hospital outcomes than non-cancer patients. And this could possibly be attributed to the fact that they don't present with the same presentation seen in the general population, which could make diagnosis more difficult. So considering that rapid identification of ACS is critical for patients to receive timely therapies, better understanding the symptoms of cancer patients is critical in order for this group to receive optimal treatment. So when patients arrive at the emergency department, symptoms are documented by nurses in a note, such as this example to the left. And these notes are brief and are meant to inform the nurses and physicians of the chief complaints of the patients, as well as a brief assessment made by the nurse when triaging the patient. So ED nurses triage patients, meaning that they are responsible for deciding how urgent a patient's case is and the ED resources that the patient will receive based on their symptoms. So symptom data is documented with great variability in terms of linguistics and content across different nurses, and it's often difficult to utilize for research. But recent studies have efficiently extracted symptoms through natural language processing techniques, but these techniques are still relatively underused in cardio-oncological research. So natural language processing, just as a definition, is any computer-based algorithm that handles, augments, and transforms natural language so that it can be represented for computation. So standardized extraction of symptoms via natural language processing could create usable clinical data potentially to study ACS symptoms. So the goals of the study were to test a novel data extraction system for the extraction of ACS symptoms in ED nursing notes, and to compare the symptom prevalence in cancer patients and non-cancer patients with ACS. So a total of 1,200 emergency department records were included in this study, and the patients included had presented to the ED with a symptom concerning for ACS. Each record was annotated by a novel data extraction system called Artificial Intelligence Data Extraction, or AID, which was developed by the Institute for Data-Driven Public Policies. And through this tool, we annotated the ED notes for the presence of ACS symptoms, and the AID extraction system then used machine learning to automatically identify 5 symptoms of ACS: chest pain, shortness of breath, fever, indigestion, and cough, based on the patterns that it learned from the manual annotation. So the performance of the extraction system was then analyzed against the gold standard of the manual annotations, and the accuracy was determined for each symptom using an F score. The results of the data annotation were also used to determine symptom differences in ACS patients with and without cancer. And after separating the cancer and non-cancer patients, independent t-tests were used to determine any differences between the groups. So of our 1,200 patient records, the mean age was 64 years, 54% were male, and 89.3% were white. Most patients were afflicted by hypertension and dyslipidemia. 13.7%, or 163 of our patients, did have a history of cancer. And 44% of patients who presented to the ED with suspected ACS did have an ACS diagnosis. And then between cancer patients and non-cancer patients, we saw that cancer patients were significantly older and more often had a history of hypertension and coronary artery disease. But ACS diagnosis was similar between the cancer and non-cancer patients. 73 of our patients had both ACS and cancer. So the AID system performed with an accuracy ranging from 0.94 to 0.99, meaning that it was able to identify the 5 symptoms properly in close to 100% of the notes. And it performed best with fever with an accuracy of 99.4% and worst with shortness of breath with an accuracy of 93.6%. Comparison of the prevalence of the 5 symptoms showed that shortness of breath was the most common ACS symptom for both cancer and non-cancer patients. Patients with a history of cancer were actually more likely to present with fever than patients without cancer, but there were no other significant differences that we found. However, we did see that chest pain occurred in only 50% of the cancer patients, as opposed to 60% of the non-cancer patients, which was an interesting finding that we saw. So the first goal of the study was to test a novel data extraction system for the extraction of ACS symptoms. And in regards to this aim, we found that the novel data extraction tool AID can efficiently extract symptoms with high accuracy. The second aim of the study was to compare symptom prevalence in cancer patients and non-cancer patients with ACS. And we found that fever may occur more often as a symptom of ACS in cancer patients than the general population. Shortness of breath is highly concerning for ACS in cancer patients, but chest pain may actually occur less than expected at initial ED presentation. For the implications of our findings, the AID system and systems like it could be used in the future to help researchers and clinicians accurately identify symptoms in ED records. And when utilized in combination with artificial intelligence systems, AID could potentially help nurses differentiate between cancer patients at high risk for ACS and those who aren't as high of a risk. Additionally, ED nurses should have higher clinical suspicion for ACS in cancer patients, and further research is warranted into the symptoms of ACS in cancer patients in order to look at a wider range of symptoms and also include a larger cohort so that we could have greater diversity and just a larger sample size in order to have results that we can extrapolate. So yeah, future work looking into these symptoms could potentially help with rapid identification of ACS and improve outcomes for patients. For my acknowledgements, I would like to thank Dr. Stephanie Frisch for her mentorship, and I would like to thank the CompBio site for all their support. And I would also like to thank Dr. David Boone, Solomon Lipschitz, and the Department of Biomedical Informatics and UPMC for this opportunity. Thank you for listening to my presentation. Are there any questions?
Thank you very much, Sophia. This was a very nice presentation. We do have time for a few questions.
I was curious about, great job again, Sophia. I was curious about the group. So it's just cancer patients. Is there any determining features that you want to break down within that group? You know, the types of treatment that they're getting, the types of cancers. Are you able to do that? Do you think that there may be differences? Some of those differences might be, you know, due to some of those differences just among that broadly cast group?
Yeah, I think for sure. I think the only issue with our study, we only had 73 patients with cancer and ACS. So we sort of had to decide early on that we were just going to look at cancer as a whole and not try to like separate into cancer type or maybe the treatment that cancer patients were receiving. Definitely, if we were able to get a larger cohort, I would want to look at those sort of features of the patients too and see if that affected their symptoms. Thank you.
Did you see anything in your data that might indicate that there are differences in the small group?
Yeah, we didn't exactly look into that, unfortunately. So I couldn't speak to that yet. Yeah.
Thanks.
Yeah, so I have a question also. Were you able to identify anything that the NLP algorithms didn't pick up? Like, were you able to look at the text yourself and say, oh, I know that this is saying something, but the algorithm itself didn't figure it out?
I can't think of a specific example, but I think commonly with NLP, sometimes the errors occur when there's negation. So if something in a note said like no shortness of breath, or it had a list maybe like no shortness of breath, chest pain, fever, it's like harder for we understand that it's the no is addressing all of those symptoms, but maybe the system, the model can't exactly understand that. So it's things like that where it's like, yeah, that would maybe be an example where a symptom would be missed or included accidentally. Yeah.
Okay, thank you. Any other questions? If not, thank you again, Sofia, and we will move on to our last speaker of the early session, of session 1, who is Anyssa Oden, who will be introduced by, I believe, Dr. Stephen Abramowitch.
Yep. So hi, folks. I'm Stephen Abramowitch. I'm from the Swanson School of Engineering, Department of Bioengineering. I do research related to female pelvic health, and specifically I look at biomechanics. So basically how we push and pull on tissues and how they function as accordingly, and certainly how disease affects that process. Anyssa has been working with me for 2 years now. She started, I guess, when she was a rising junior at SciTech, and now is a rising senior. We've actually worked throughout the school year last year, so I know Anyssa quite well. This year we decided to pivot a little bit, still focusing more on computational work, which is kind of where my interest has been over the last 5 years or so. And it lends itself obviously well to kind of some remote research. But Anyssa has last year did some work looking at delivery and trying to simulate delivery computationally. This year we kind of switched gears. There were some really nice developments in the field of computational modeling, specifically for biomechanics, that we wanted to start taking advantage of, but they're not really robust yet and implemented into commercially available software packages. So Anyssa's kind of giving us a leg up, if you will, by helping us incorporate some of these new developments into some of our workflows. So that's what she's going to talk about, and I look forward to her presentation.
Thanks, Doc. Okay. All right, you guys can see my slides.
Yes.
So my project this summer obviously was about using incremental potential contact, or IPC, for computational simulations of urogynecological mesh. So for some background, I'm first going to talk about what these mesh are and their purpose. And so basically they're surgical mesh are implants, and their purpose is to repair pelvic organ prolapse. So what that is you see in this figure here, these are the pelvic organs. And pelvic organ prolapse is when the pelvic floor muscle becomes too weak to hold up these organs in place. And so one of them may collapse and start to push into the vagina or each other, basically. So the purpose of these mesh is to sort of simulate the pelvic floor muscle and hold them up, hold the organs into their place. But there are some drawbacks with the mesh implants. So a lot of them are associated with complications like inflammation and infection when they're being inserted surgically. And this is because of their textile properties. So what I mean by that is here in figure 2, you can see that there's these are different meshes and they all have different shapes. And so their mechanical behavior is determined by sort of their textile shape. So with their mechanical behavior, they have different elasticities and different stress handling capabilities and deformation. And so this is important in computational biology because we want to be able to simulate these different shapes of mesh before using them to avoid the complications that I talked about before. And while that's good in theory, there are a couple of issues with simulating mesh, and the main one comes from the interaction of the mesh filaments. So here's a close-up of one type of mesh. And as you can see, there's a lot of like different threads that are really close together and touching each other. And so software has to be able to simulate the points of contact between all of these filaments accurately in order to in order to be able to sort of predict how a mesh would react in real life. And so the current computational limitations with this is that trying to simulate friction for materials that are going through large deformations. So with mesh, performing uniaxial tensile tests where it's being pulled from opposite ends, it's hard for computers to accurately simulate that because of all the points of contact. And because of that, it can lead to element inversion, which is where the mesh will collapse in on itself in the simulation, or penetration. So these threads start to sort of go through each other when obviously they're supposed to be separate. And so a solution to this was a recently developed algorithm called incremental potential contact, or IPC. And its job is basically able to accurately calculate these areas of contact. So it is able to calculate the friction and it produces more accurate simulations that involves friction. So here's an example of so the group that developed this algorithm. And so not only can IPC simulate that friction, but it's also able to simulate simulations of collisions. And so while all of that's good in theory and it's helpful, there's a big drawback to IPC. And that main thing is that it doesn't have a graphical user interface. So it's basically a bunch of code and it's hard to use for these simulations because there's no GUI. So my job this summer, was to develop a workflow between Houdini, which is a 3D software, and IPC to increase the efficiency of running simulations using IPC. The importance of Houdini is that it has a graphical user interface, but it's not able to run those simulations with friction as well as IPC can. And the drawback of IPC is the graphical user interface. So being able to sort of mesh these together is sort of the importance of it. And then my second goal was to demonstrate the workflow working by simulating a urogynecologic mesh in tension, so it being pulled from opposite sides. Methods for this were very extensive. The first thing I did this summer was learn coding in Python because I had no previous experience. And in Houdini, you're able to use Python to customize your simulations or whatever you're building inside of it. So this is just an example of some of the work that I was doing, just making functions and codes on my own, and just in order to understand sort of the keywords in Python and sort of what makes it work, because the syntax is important when you're coding. So after I did that, and I had a basic understanding of Python, I had to inspect the IPC code because it's sort of, it has its own syntax. So here's an example of sort of a file that IPC reads in order to simulate or run the simulations. And I had to be able to understand what all these numbers and words mean in order to go from Houdini to IPC. And the main thing that I found with this is that IPC uses a different coordinate system than Houdini. So with IPC, it uses a coordinate system that's sort of based on the object. So if we had a graph, then the 0 would be like in the dead center of that object. And then the points, the rest of the points from it are sort of based on that. Whereas with Houdini, it's sort of a global coordinate system. So it's not based on the object, but rather where you move that object in that space. So the workflow had to be able to translate that in order for it to work. So here is the result of that. So on the left, you can see here is, the gray part is a mesh. And so what I did was I imported a mesh file into Houdini. So that's what that is. And then we use Vex, which is another, it's a coding language specific to Houdini, in order to translate the coordinate system from the global one that Houdini uses to the object specific one that IPC uses. And so it automatically does that. And then we added bounding boxes, which is in teal, so that you could select points on the mesh. And that's what the orange, all the orange is the points on the mesh that are inside those bounding boxes. So when all of this is, when the boundary conditions are exported to IPC, then those are the points that'll be, I guess, sort of moved when IPC is running. And so here's an example of urogynecologic mesh before and after deformation in IPC. So you see before deformation, it's before the uniaxial tensile test. After is when the mesh was stretched out in both directions. And so the main takeaway from this is that there's no element inversion and there's no penetration between the mesh filaments. I don't know if that's sort of hard to see, but all of the filaments are separate, and IPC is able to accurately sort of demonstrate this mesh and its mechanical properties. So that's what is sort of great about it. So in conclusion, I was able to successfully create the workflow from Houdini to IPC. And then I was able to demonstrate that urogynecologic mesh in tension. So just to demonstrate that IPC works and that the workflow is working properly. And so my next steps are going to be to create another workflow that selects specific points on the mesh rather than having to use the boundary box to select points, because with IPC, it's sort of difficult to select specific points because of that translation. So that's going to be the next step. For my acknowledgements, I'd like to thank my mentor, Dr. Stephen Abramowitch, as well as David and Solomon, the YES program and the University of Pittsburgh and the National Institute of Health for this opportunity to do research again this summer. That's all.
Thank you very much, Anyssa. Are there any questions from the audience? So something that I want to know is, engineering is cooler than medicine, isn't it?
I feel like there's sort of, well, my work these past couple of years has sort of been a combination of both, and that's what I like about it, is that it's taking engineering and applying it to real life solutions to help people. And so I think that's the best crossroad about biomedical engineering.
Okay,
So,
excellent answer. Excellent answer.
So Anyssa, this is something that I haven't actually been able to ask you in a long time. But how has just this experience of the last 2 years shaped your impression of, different career choices, potential majors in college, those types of decisions?
well, I know the first time that we met, I said I wanted to be a pharmacist, and I think that's sort of changed now. I'm definitely interested in biomedical engineering. There's so many different areas to it, like what we're doing, but then there's also sort of the medical device aspect to it as well. And there's so much to explore with this that, it's great.
I like that answer, of course.
Of course.
Yeah, that's great. Are there additional questions? Okay, so I think that this is reinforcing the idea that yes, we are having some impact on our scholars' career choices, right, and on their futures. I really enjoyed all of these talks in this session. I think that we can give a big round of applause to all of our first session speakers. Right now, we are oddly, we are actually 3 minutes ahead for our break. What we will do is take a short break and reconvene at 10:45. I will pause the recording during that break so everyone can go out and walk the dog or have your discussions even here without being recorded, and then we'll resume promptly at 10:45. So thank you very much.
So I can't hear you. You can hear me though?
Yes, I've been talking on mute. Sorry. Thank you. So we'll finish off. We have 5 speakers, or perhaps fewer, in this session. And our first speaker is going to be Emilia Kartsonas.
It's my pleasure to introduce Ms. Emilia Cortzolis, who joined our research team at the Hillman this summer remotely. She is a rising senior at Aquinas Academy in Pittsburgh, where she has a 4.0 GPA. So we were very happy to have her. And this summer, she took on the challenge of helping us to double check data that was collected as part of an ongoing biobehavioral study of the effects of acute psychological stress on DNA damage that was assessed in white blood cells collected from healthy human volunteers. And she did an outstanding job at that. And while the DNA damage data is still being collected, Emilia's project looked at the effects of that acute stress on the white blood cell counts and the composition of those white cells phenotypically. in the blood samples, which could affect the outcome of the later DNA assessments. So I want to thank Emilia for her hard work, and I look forward to her presentation. Emilia?
Thank you. I'm going to share my screen. Okay. Can you all see that my presentation is showing?
Yes.
Great. Thank you. Hello, my name is Emilia Kartsonas, and as Dr. Bovbjerg said, I am a rising senior at Aquinas Academy of Pittsburgh. And this summer, I worked with Dr. Bovbjerg and Jessica Mankulich on a study of brief stresses and DNA integrity, with a particular focus on the effects of stress on white blood cells. The overarching goal of the research was to determine if repeated exposure to acute psychological stress may cause DNA damage and, after repetitive exposure, eventually lead to an increased cancer risk. There are many known causes of DNA damage, ranging from UV radiation to toxic byproducts of cells or just replication errors by the DNA itself. And this study seeks to identify psychological stress as another potential cause of DNA damage. However, not all DNA damage is harmful. In fact, it's very common for the DNA to mutate and for there to be errors in the genome. So the problem arises when, over a long periods of time, the repair mechanisms that our bodies have for our DNA start to make mistakes, and those mistakes can accumulate into DNA damage that can be harmful and eventually lead to an increased cancer risk. The three main aims of this experiment were first to test how acute stress impacts DNA while simultaneously testing a drug that has the potential to block DNA damage by blocking beta adrenergic receptors. Second was to identify possible mediators between acute stress and DNA damage. And third was to investigate the effects of demographic variables, so taking into consideration how a participant's age, sex, and race affects their susceptibility to DNA damage. So those were the main goals of the overall research, and what I focused on this summer was the second aim, which is identifying a possible mediator between acute stress and DNA damage. And the mediator I looked into was white blood cells, and specifically the volume of white blood cells and how it is affected by stress. So white blood cells are a known marker for DNA damage, and their increased volume of white blood cells can affect DNA outcomes. So therefore, white blood cells could be a possible mediator between acute psychological stress and DNA damage. This leads me into the purpose of my study, which was to explore the possible effects of acute exposure to a standardized, well-established psychological stress task. In this case, it was the Trier social stress test on white blood cell counts. So in order to determine the effects of stress on white blood cell counts, there needed to be a way to compare the cell's reactions to the stress as opposed to just a baseline. So this study was designed with 2 experimental days, a stress visit where participants were exposed to the TSST, and a control visit where they completed a task in the same time frame as the TSST. On both days, urine and blood were collected and heart rate was continuously monitored so the labs would be comparable. And as mentioned before, demographic variables were considered in the study, so all participants were selected from healthy adults with no pre-existing conditions that could impact their stress response, and they were aged 20 to 59 of varied sex and race. Okay, this figure is a deeper look into the timeline of the stress visit and the TSST timeline. On the left here, where my cursor is, these are different variables that were either collected or monitored during the stress visit, and the black circles or squares are the times of when they were collected or recorded. And at the top is just the timing in increments of 5 minutes. As you can see, there were 3 major periods during the stress visit. First, a 60-minute baseline period, which consisted of self-reported data by each participant, as well as a video distraction. The second was the actual stress task period, which was 15 minutes and consisted of participants giving a short speech, as well as with little time to prepare, as well as an arithmetic task, which were complex subtraction questions, and participants did this all in front of an evaluator while being recorded. And third was a recovery period, which was also 60 minutes and was just a video distraction. As mentioned before, one of the aims of this study was to test a drug's potential to limit DNA damage. That drug was propranolol, and it was administered here at the start of the baseline period, so 60 minutes before the TSST. Participants were either given propranolol or a placebo drug in a double-blind fashion. The three important samples for my study this summer were the blood samples collected immediately post-baseline, post-task, and post-recovery period, and these were the samples that were looked at to compare the white blood cell counts changes in response to stress. Once the necessary blood samples were collected and the labs were done, the plasma volume change needed to be corrected for the blood volume. So what this means is that post-stress and post-recovery, there was an immediate decrease in the plasma volume of the blood, and this decrease, so plasma, the fluid of the blood, was lost to surrounding tissues. And what this does is it can make the results misleading because it can make it seem like there was a large increase in the concentration of white blood cells, possibly due to the stress, when really it only looks that way because of the significant decrease in the plasma volume. So this equation was used to correct the plasma volume, and what this solves for is the total change in the whole blood biomarker. In this case, the biomarker was white blood cell counts. And this bottom right corner, this part of the equation, is what was used for my study. So the variables that were used to calculate this for post-stress and post-recovery white blood cell counts were the white blood cell counts of post-stress or post-recovery divided by the baseline white blood cell counts times the baseline hemoglobin levels divided by the hemoglobin levels post-stress or post-recovery, all -1. Once these calculations were performed, it was found that there was still a significant increase in the white blood cell counts from baseline to post-stress before and after the plasma volume correction. So after, it was about 7%. And so the plasma volume did not affect the results of the cell count analysis, and the white blood cell increase was due to stress, not just the decrease in plasma volume. These graphs show the absolute cell counts of white blood cells and different white blood cell subtypes. And the data that is presented on the graphs are averages that were calculated from all participants' white blood cell counts at baseline, stress, and recovery. So this first graph of white blood cells, as you can see, the values showed a significant increase from baseline to stress as well as baseline to recovery. And then neutrophils are just a white blood cell subtype. They follow that same pattern and show a significant increase from baseline to stress as well as baseline to recovery. These are two more absolute cell count graphs of white blood cell subtypes, lymphocytes and monocytes, and they both show significant increases from baseline to stress. And while there's less of an increase from baseline to recovery, it still increased, and that was still significant for the results. In conclusion, it was found that white blood cell counts did increase significantly in response to stress, and therefore white blood cell counts was able to be identified as a possible mediator between acute psychological stress and DNA damage. In the future, studies could look at the specific mechanisms for how white blood cell counts impacts DNA and whether it only impacts a participant's sensitivity to DNA damage or whether it actually causes DNA damage itself. I would like to thank my mentor, Dr. Bovbjerg, as well as Jessica Mankulich, whose help on this project was great and invaluable, and also Maria Ramos, who worked on part of this project with me. I would also like to thank Dr. David Boone, Solomon Lifshitz, and the UPMC Hillman Cancer Center for this opportunity, as well as the participants in the study and the National Cancer Institute. Thank you. Are there any questions?
Thank you very much, Emilia. Are there any questions from the audience? I can start us off again and ask, so after giving this presentation, how are your white blood cell counts?
They're good. They're recovering.
Recovering, okay, very good. Are there, so then now let me ask something else. What's a good way to follow up on this study?
So I think, like I mentioned, looking now that white blood cells can be identified as a possible mediator between DNA damage and stress, just looking at the specific impact that white blood cells can have on the DNA damage and how, like, the mechanism for how the mediation happens. So what it actually does to impact the changes that stress causes.
Okay, and is this just for white blood cells in general, or for different types of white blood cells? Is there any interest in looking at differences in types of white blood cells that might change?
Yeah, that is a direction that the research should go in. There were also tested basophils and I think one other subtype of white blood cells, and those actually didn't have a significant change like the neutrophils and monocytes and lymphocytes did. So that could potentially be looked into for what specific types of white blood cells are impactful for DNA damage.
Great, thank you. Any other questions from the audience?
Emilia also learned about flow cytometry, which we weren't able to get to this summer.
Yes, unfortunately. All of the lab operations had to be postponed. Okay, so thank you again, Emilia. And then our next speaker is Maria Ramos.
It's my pleasure to also introduce Ms. Maria Ramos, who remotely joined our research team at the Hillman this summer. Maria is a rising junior at Germantown Friends School in Philadelphia, where she's very interested and proficient in STEM and computer science areas. And this summer, she took on the challenge also of helping us to double check the data collected as part of the ongoing biobehavioral study that you just heard about, working as part of a team with Emilia. And she too did an outstanding job on that. For her project, Maria decided to apply her computer science skills and learn a new statistical package to explore possible causal relationships among some of the key variables in this study. She focused on the independent variable that you've just heard about, of a randomized assignment of the participants to groups that either received pretreatment with placebo or with propranolol before the stress. And we had outcome variables, as you heard, of white blood cell counts, but also heart rate changes, both of which were anticipated to be affected by stress. Since the statistical approach that Maria chose to learn is beyond my expertise, she was essentially flying solo in this analysis. And I want to commend her on that act of bravery. And I look forward to learning more about the results of that project along with you in this presentation now. Thanks, Maria.
One second, let me get this to work a bit better. Okay, thank you, Dr. B. Okay, so my project investigated heart rate as possible mediator between beta blocker administration and changes in white blood cell counts following a brief psychological stress. So the overall broader study investigated acute psychological stress, which may cause DNA damage. Imperfect repair of DNA damage does increase cancer risk over time. So how we observe DNA damage is by examining white blood cell count and the damage levels. These damage levels are used as marker of systemic effects on DNA integrity. And stress exposure is also known to increase white blood cell count. Because stress exposure is known to cause white blood cell count increase and is being examined as possibly causing DNA damage, it is possible that white blood cell count increase could influence DNA damage outcomes indirectly. So, my project focused more so on the mediation aspect. But to give some background, the trier social stress test is a method known to induce acute psychological stress through participants performing stress tasks of a level consistent with common daily stressors. TSST is known to affect the sympathetic adrenal medullary system, immune system, cardiovascular outputs, gastric function, and cognition. So participants were split into two groups per panel, beta adrenergic antagonist and placebo, and underwent TSST. During this time, heart rate and white blood cell counts were reported. So in this project, heart rate and white blood cell count data were collected before and after TSST, and participants were randomized to receive placebo per panel, a beta adrenergic antagonist, in a double-blind fashion. The objective of the present study was to explore a mediational role for stress-induced changes in heart rate as a proxy for beta adrenergic stimulation and effects of stress exposure via the TSST on white blood cell counts. So heart rate would be considered as an intervening variable between drug taken following stress as a predictor and white blood cell count changes outcome. So what the packages do, Lavon and Simplot packages are known to conduct mediation modeling and visual representation of path analysis, which were both needed in this study. So methodology. As seen in this diagram, 95 study participants were assigned to take either placebo or propranolol 60 minutes before the TSST exposure, and blood samples and heart rate measures were collected before, during, and after, like I stated, and differences in white blood cell count and heart rate were calculated and then used in the Lavon structural equation model. So here you can see better the equations that I used in R with this package. So heart rate being the potential mediator, M regressing on the drug taken, which would be in this case the X variable, and white blood cell count changes, the Y variable, regressing on heart rate changes, M, and drug taken. So indirect and direct, as well as total effects of paths, were examined through equations manipulating model A, B, and C paths. So you can see a bit more of that here. Moving on, the results that I got were very helpful. So the model was processed and summarized, then plotted using Simplot and TidyR packages. Multiple indexes presented in the summary were used within reasonable measure to indicate functionality and model accuracy. And these index tests met preferred ranges. So as you can see here, the chi-squared test, the p-value was less than 0.05. The comparative fit index was greater than 0.9, and the Tucker-Lewis index was greater than 0.95, which meant the model was functioning well, and we could then examine other values calculated in mediation. So these are those other things that were estimated by the model that I just talked about. So this figure shows summarized results of structural modeling equation with a focus on regression. Here, regression shows the associations between the predictor and variable and outcome. So HR is positively and significantly associated with white blood cell count, and so is the drug administration, and drug administration is also positively and significantly associated with heart rate. The variance section represents the residual error. Residual error is the measure of how well aligned fits an individual data point. So residual error is the difference between those two things. And because the other residual error is not too high, so if you can see the heart rate variances, this estimate number is very high. So that shows that there is large residual error. However, this did not stop our analysis of the model, because residual error doesn't necessarily mean that something is wrong with mediational analysis, but it likely means that there is some unexplained difference that can be investigated later. And the white blood cell count residual error was not too high. So R-square values shown indicate that collectively heart rate and drugs taken account for 20.4% of white blood cell count change. And we could have predicted with our high residual error, drug taken only accounts for about 2.7% of heart rate change. The direct effect, indirect effect, and total effects found are defined in the parameters estimate summary. So the direct effect was 0.076, the indirect effect was 0.079, and the total effect was 0.154. So this proved that mediation paths A, B, and C were significant in impact of drug taken on white blood cell count and mediation. This is a visual representation of what we just saw in path analysis. So using SemPlot, this conveys Levon mediation model summary results of standardized parameter estimate as weighted edge labels. So you can see that here. And this is another visual model that represents path analysis using the graph sem function, which is through TidyR. And this conveys the mediation model summary results of regression estimate as path values and variance estimates as residual error. So this is my discussion section. So because this isn't an experimental analysis, the residual error can give us more information about future study. Examining sources of residual error could indicate heart rate as a possible mediator between another X variable and white blood cell count that could be determined by modeling that would be useful in the broader study. Additionally, an extension of this study would feature path analysis examining 5 additional mediation models with differences in absolute differential lymphocytes, monocytes, basophils, and eosinophils, neutrophils as Y variables. This study's mediational model, along with those 5 additional models mentioned, could influence the interpretation of the results of the broader study as an experimental check of the effects of propranolol on outcomes in various cell type counts